Welcome to our training regarding client records management and the use of technology for documentation. We will look at general client record management issues and then specifically consider electronic health records. This training includes viewing this PowerPoint presentation and then completing the attached quiz with a passing score of at least 70%. There is a copy of the PowerPoint slides available in the lesson media section of this lesson. We hope that you enjoy the training. For every individual that we serve, we are required to maintain a single clinical record. As we will discuss later, that record can be completely electronic, a combination of electronic and paper, or, if we go way back to the old days, completely paper. The key point is that whatever items that we identify to be included in the record must be kept in a single record. We are not permitted to maintain separate records if an individual is served in more than one of the programs at our organization. The requirements for the client record go on to say that the record must be complete, accurate, accessible, and secure. We want to make sure that important and relevant information is included in the record and that the entries in the record are accurate. If you make an error in an entry, there are ways of correcting the error regardless of what system you may use for your records. For a provider who wishes to make an entry into the record must be available to that person. And finally, the record must be secure. Specifically, information in the clinical record meets the definition under HIPAA of protected health information, or PHI. There is another training in this series that discusses the confidentiality issues related to HIPAA and 42 CFR Part 2. Clinical records should be organized in a way that makes it easy to find where information is stored in the record. Back in the day of paper records, the file had tabs to identify where items were located. With electronic records, there are typically electronic tabs that store similar information together. The clinical record maintains its confidential status regardless of any prior releases of information, whether authorized or not. Important in this discussion for individuals that we serve for a long time is that releases of information typically have an expiration date on them, and we must renew them to be able to continue to release information. Regarding security of records, the regulations refer to double locks, which is a reference back to paper charts, where the charts would be in a locked file cabinet behind a locked door, or in a locked room behind a locked door. With electronic health records, we can interpret double locks to mean that the system that stores the record must have physical and cyber security components, and that access to the records is secured through user IDs and strong passwords. Finally, as we discussed in our training on HIPAA and 42 CFR Part 2, the confidentiality regulations limit access to records to a need-to-know basis. When we were dealing with paper records, it was important that records be in a locked container when they were being transported. With electronic records, this issue has become less of a concern. However, we sometimes complete paper documents with the people that we serve while we are in the community. These paper documents will become part of the clinical record, so it is important that we have a method for securing these documents while we are transporting them back to the office to be placed or scanned into the clinical record. The single clinical record for a person served shall also be assigned a unique number that identifies this record. We cannot use any personally identifying information, such as a social security number, address, or date of birth, for this number. Ideally, the number should be randomly generated, but it is also acceptable to assign numbers sequentially as individuals are admitted to our programs. As previously discussed, most records are now electronic, but may still contain some paper elements. When we have scanned a paper document into an electronic record, it is not necessary to keep the original paper document. Organizations are required to keep records following services for a defined period of time. For adults, clinical records must be maintained for at least 7 years from the last date of service. For minors, the clinical record must be maintained for at least 7 years from the last date of service, or for 3 years after the person turns 18, whichever is longer. So if we provide services to a 10-year-old child, the normal 7-year provision would suggest that we could destroy the record when the person was 17, but the additional 3-year restriction requires that we maintain the record until that person turns 21. We must keep the records in case the person would want information from the record at a future date and for other legal-related reasons. When there is an identified need to protect a record from staff members at the organization, a process of securing the record is to be implemented. This process is called sequestering a record. The reasons for sequestering a record may vary, but common reasons include the patient being related to a staff member, a patient death, litigation regarding the patient, or the patient has some level of community notoriety. Records can be sequestered from all staff with specific permission to specific staff members to have access, or they can identify specific staff members who cannot access the records. For paper records, the process of sequestering the record involves moving the record to an additionally secured location away from other records. As stated on the previous slide, there are a number of reasons to sequester a record. These reasons are listed here on this slide. Please take a moment to review these reasons. Finally, if a record is still considered sequestered for any of the reasons given, it may not be destroyed, even if the mandatory time for maintaining the record has expired. When dealing with clinical records, and especially electronic health records, it is important to build a security-conscious culture within the organization. One key activity that should be completed by all organizations is a security assessment. This security assessment should define the strengths and weaknesses of the security of clinical records. The assessment should then be followed by a security plan to address the identified weaknesses in security. Additionally, security of the clinical record needs to be a priority within the organization. The topic should be frequently discussed so that all staff members know that security is a priority. This culture will help everyone to make decisions with the security of the record in mind. Finally, security is not just for our information technology department's concerns. Security needs to be a concern for all staff members of the organization. One of the best ways of securing electronic information is the use of complex passwords. To decrease the likelihood that a password can be compromised, the password should be more than 8 characters long Include both upper and lower case letters. Yes, passwords are case sensitive. And include numbers and symbols. Don't make your password your name with the first letter capitalized followed by a 1 and an exclamation point. If you use words in your password instead of just random letters, you should use at least 2 words that are unrelated. So instead of houseboat 1 exclamation point, you might consider HOUSE and 3 ABLE number sign 24. A password doesn't do you any good if you write it on a sticky note and put it on your computer. If you must write down your password so that you can remember it, it should be stored in a secure location away from your computer. Passwords should be changed frequently. Many organizations will require the changing of passwords somewhere between 30 and 60 days. Also, as a part of the security of electronic information, do not share your username and password with anyone. If you are using an electronic record, please make sure that you are the one that is logged into the record, especially when you are using a computer that is available to multiple staff members. Finally, if you suspect that your password has been compromised in any way, please report your suspicions to your IT department and then change your password. We also need to be very aware of our security protocols regarding our use of email. Email is the most frequent tool used for a cybersecurity attack. If an attack gains access to our computer, then the attacker gains access to all information contained on the computer, including any confidential information that may be stored on their computer. Since our work computers may link to our electronic record system, an attack may present a risk to the security of our clinical records. Everyone needs to be aware of the steps to protect our assets from an email attack. The recommendations for protecting our computers are provided here. Please take a moment to look at the email security recommendations. There are a number of cyber attacks that come through email. The most common is spamming, which is an unsolicited message sent to your email. Many email programs have spam filters which move these emails to a contained location on your computer. Spam is more of an annoyance than it is a threat. Spoofing moves up to the level of threat. In spoofing, an email header is forged so that the message appears to have come from someone other than the actual source. The spoofer hopes that you will trust the source and open and perhaps respond to the content of the email. Unfortunately, much of the ransomware is sent through spoofing. Ransomware encrypts all of the files on a computer and requires the user to pay a fee to gain access to the files. Ransomware can be installed on your computer simply by the user opening an attachment in an email. One ransomware attack that I have personally received is from a messaging company, which is spoofed, that says that the user, me, has received a fax transmission, and there is an attachment to the email identified as a fax transmission. If the user opens the attachment, it will install ransomware on that computer and may install the ransomware on every computer attached to the network. There have been a number of significant and widely publicized ransomware attacks, including attacks on the San Francisco Transit Authority, the Colorado Department of Transportation, the City of Atlanta, the Port of San Diego, and the cities of Riviera Beach and Lake City in Florida. Riviera Beach paid a ransom to the attackers in the amount of $600,000. Lake City paid $460,000. The City of Atlanta refused to pay the ransom of $51,000, and it is reported that they spent over $17 million restoring their system. Think what an expense like that would do to your agency. The next type of attack is phishing, which is where the attacker attempts to disguise their identity and pretend to be a trustworthy source, such as your bank, to gain sensitive and private information from you, such as usernames and passwords and financial information. Never, ever, ever send your username and password to anyone through an email. Never, ever, ever send financial information, including your social security number and your bank account numbers, to anyone through email. If you are involved in a financial transaction, such as buying a house, make arrangements for how to deliver your financial information in some other way. Finally, there is pharming, where the attacker attempts to redirect traffic to a website that is under the attacker's control. As an individual user, we will not see pharming attacks. These are attacks that your IT department needs to be aware of, and the IT department manages these attacks. So, within a security-oriented culture, there are a couple of things to remember. First, the confidentiality regulations and laws require that access to clinical records and protected health information be on a need-to-know basis. Therefore, the casual viewing of any information in the clinical record is prohibited. Next, we need to protect the information that appears or is maintained on our computers. We need to have our computers go to sleep when there has not been activity on the computer, and the password needs to be entered to wake the computer up. When we are using a shared computer, we need to log off the computer when we leave it. In our offices, where possible, we want to position our monitors so that others cannot see what is on the monitor. And finally, protect our passwords, protect our passwords. With all of the risks regarding the sending of an email, how can we safely transmit confidential information? There are actually a couple of ways. First, if the person receiving the information just needs information and not documents, we can deliver the information by telephone. We want to make sure over the telephone that we know who we are talking to and that we have a release of information for the information that we're sharing. If the person we're giving the information to actually needs copies of documents, we can deliver those in one of two ways. First, we can hand deliver the material. It needs to be sealed in an envelope and marked confidential and carried in a secure bag until delivered to the other person. Second, the information can be sent by encrypted email, which is considered a secure method of transmitting electronic information. You want to talk to your provider about the processes for using encrypted email. There are additional safety measures that we need to take for our work-related mobile devices, such as phones, tablets, and laptops. If our devices, including any storage devices that we might be using, such as a thumb drive, if those devices store or access any clinical records or other confidential information, we have to take additional precautions. All devices that may access confidential information must be encrypted in order to limit access to the information. We must be especially careful when connecting to a wireless network when we are away from the office, as wireless networks are not secure. In order to use an unsecured wireless network, we need to have either Wi-Fi encryption or a VPN installed on our devices. The mandate for and the development of electronic medical records or electronic health records was the result of three significant pieces of federal legislation. First, the American Recovery and Reinvestment Act of 2009, better known as the stimulus package, required all public and private health care providers to adopt and demonstrate meaningful use of electronic medical records by January 1, 2014. Penalties for failure to implement the EMR were reductions in Medicaid and Medicare reimbursement. The Health Information Technology for Economic and Clinical Health, or HITECH Act, was a part of the legislation made up in the American Recovery and Reinvestment Act. The benefit of the HITECH Act was that it provided financial incentives for implementation of electronic medical records. Finally, the requirements and specifications for electronic medical records was further promoted in the Patient Protection and Affordable Care Act of 2010. The Health Insurance Portability and Accountability Act, or HIPAA, security rule established a national set of minimum standards for protecting all electronic protected health information. The security rule contains the administrative, physical, and technical safeguards that must be put in place to secure the electronic information. These safeguards can help providers avoid some of the common security gaps that could lead to cyber attack intrusions and data loss. Safeguards can protect the people, information, technology, and facilities that providers depend upon to carry out their primary mission, caring for the individuals served. The security rule has several types of safeguards and requirements. First are the administrative safeguards, which are actions, policies, and procedures designed to prevent, detect, contain, and correct any security violations. Administrative safeguards involve the selection, development, implementation, and maintenance of security measures to protect the electronic information and to manage the conduct of staff members in relation to the protection of that information. One of the requirements is that agencies should perform a security risk analysis that identifies and analyzes risks to the electronic protected health information, and then implement security measures to reduce the identified risk. Second are physical safeguards, which are the physical measures, policies, and procedures to protect the electronic information systems and related equipment from natural and environmental hazards as well as unauthorized intrusion. Third is the organizational standards, which require a provider to have contracts or other arrangements with other organizations that will have access to the electronic protected health information. The standards provide the specific criteria that are required for the agreements. Finally, are agency policies and procedures, which require the provider to adopt reasonable and appropriate policies and procedures to comply with the provisions of the security rule. A provider must maintain, until 6 years after the date of their creation or last effective date, whichever is later, the written security policies and procedures and written records of required actions, activities, or assessments. The provider must periodically review and update its documentation in response to environmental or organizational changes that affect the security of electronic protected health information. Digital technology and electronic health records have become a key strategy in the healthcare reform process, with adoption of electronic health records in healthcare organizations being incentivized by policy and legislation. Research on electronic health records has primarily focused on the efficiency and effectiveness of care, with mostly positive findings. One of the other major movements within healthcare reform is person-centered care, where the care is respectful of and responsible to individual preferences, needs, and values, and ensures that the person being served guides all of the clinical decisions. There are some concerns that electronic health records may be interfering with person-centered care. The reason for a lack of person-centeredness in documentation can be that the EHR itself is built in such a way that it precludes the provider capturing the individual person in terms of key biographical details. In mental health settings, the client's narrative is a central part of the treatment plan. However, in an electronic health record, open-ended questions might become closed-ended questions when they are driven by drop-down boxes and computerized decision trees. Providers have found that the drop-down boxes and predetermined goals could not adequately reflect the uniquely varied goals of the person being served. One of the reasons for this mismatch is the fact that the electronic health record does not have the sole purpose of facilitating person-centered care, but has multiple purposes that often require uniformity for the purposes of aggregation. This being said, the electronic health record can be a barrier to the delivery of person-centered care. Our responsibility is, knowing this to be the case, we need to develop strategies to assure that we are still able to provide person-centered care in spite of whatever electronic health record we may be using. That completes our presentation regarding records management and the use of technology for documentation. Again, after completing this presentation, you are required to complete the attached quiz with a passing score of at least 70% to successfully complete this lesson. Thank you, and good luck with your quiz.